Basically, this is the lower limb alignment. This lower limb is having an articulation at the acetabulum, at the knee joint, and at the ankle joint. Okay, so we are having a lower limb that is measured indirectly at the level of the hip, directly at the level of the knee and the ankle. This is the basis. Okay, indirectly means we have the innominate bone over here, and this is the reference point. We call it as an anterior superior skull. So this bone is very easy to see and palpate. In a real person, we have to palpate by walking on the bone. This is the bone continuity, and this is the first dip we are having. So this is the one point, one way to identify the ASIs. So the second way is what is attached? There is a inguinal ligament is attached. You trace along the inguinal ligament, the pulp of your thumb will be just touching the first point of contact in the area. That is the ASIS. So this is the best method. That means you are walking on the soft tissue and hitting against the bone. This is a very standard method. You can alternatively walk on the bone and get the first bit. So your first point of reference is finalized. This is the ASIS. As you walk on the inguinal ligament, the first point of contact by the pulp is the reference point. You mark it. Okay. The second point is you can have a joint line. The medial joint line. The third point is the medial malleus. So those things are subcutaneous. You can very well identify. So the limb is measured indirectly at the hip. That means we are taking a reference point far above the hip. That is the ASIS. Okay. And the medial joint line and the ASIS from lateral to medial we measure with using the tape. In case of a varus knee, which compartment will be narrowed? We will say it once we varus means joint will be reclined. That means the medial joint space will be very much narrowed and the lateral space will be somewhat increased. Okay, so this may not be a two-dimensional deformity. It will be slightly flexed and a varus will be present. In that case, you will be having a medial joint line narrowing prominently visualized. Okay, that's one point. The point number two is the ASIS to medial malleolus is the entire limb, indirect measurement of the entire limb. And if you are going to measure compartment wise, the knee and the leg compartment as well as the thigh compartment has to be specifically mentioned in the total measurement. The total measurement is X, on which one is a leg compartment, another is a thigh compartment. This thigh compartment is having 2 points. One, there is a trochanter, above which we do not have any reference points to refer. Trochanteric is subcutaneous, you can measure this. And ASIS is another point which is in a separate bone. So if you are going to measure the supratrochanteric shortening, that means a bi-segment shortening that is happening in the supratrochanteric region, you have to measure it using a Bryan's triangle method. Bryan's triangle is nothing but you have two reference points. One is ASIS, as I already told you. Just drop the tape from here to the pouch. That will produce a vertical line on the thigh. Okay. And the second point is the trochanter. So trochanter tip is the common point of the trochanter is easily palpated by internally, slightly internally rotating the thigh, and you walk along the, or you can have a soft tissue. That means the gluteus can be there. The vastus ridge is vastus lateralis extensor. Okay. So this is the reference point, second reference point. So you drop a line connecting to the first line. So you get a base. That we call it as a base of a triangle. That triangle is called Bryan's triangle. So if the patient is going to have a varus at the level of the proximal femur, that means the neck shaft angle is decreased. This angle is going to decrease like this. That means the shortening, the limb will be shorter. If this angle is going to increase, there will be lengthening. So a supratrochanteric measurement will directly tell you whether it is a varus or a valgus deformity happening at the supratrochanteric region. So if it is going to be a varus deformity, there is a shortening. This shortening is reflected in the base of the Bryan's triangle. So these 2 points will be here. So this is the measurement of the Bryan's triangle if it is going to be shorter. This is the normal. So you'll be having base of the Bryan's triangle getting decreased. In that case, you measure the varus and valgus of the supratrochanteric shortening indirectly. Okay. So this ASIS medial joint length is divided into two segments. One segment is the supratrochanteric region that is measured by base of the Bryan's triangle, and the second is a whole limb that is indirectly measured from the ASIS. We do not have a reference point on the head or the neck where we have a standard replicating model. It's not present. Okay. And then I have told about the deformity. If the person is going to have a deformity, the measurement is actually will differ from the normal side. Obviously, it will differ. But to exactly quantify, what you have to do is you place the other limb also in an identical position. So you place in an identical position so that you get the deformity measured in a same manner. So all the reference points are aligned in the same manner. So in a deformed limb, if the deformity can be replicated on the other side, replicate it and do the standard measurement. So this is regarding true measurement. There is another thing called as apparent measurement. Though you will be learning apparent measurement first and the true measurement last in the standard text, it will be better to go the other way around. This is how you have to measure the true measurement. Apparent measurement is we are not bothered about the affected limb at all. This is affected means we will leave it as such. This is the normal side. So as I told, these things can be compared by placing it identical position. But we do not do anything. We measure it as is varies. We just keep the person as comfortable as he is. And then we do not have a reference point. What will we do? We refer from the midline. From any standard point in the midline, from the notch to the sternum, wherever it is. From the midline, again the lowermost tip is measured. The entire thing is indirectly measured. So why we should do the apparent measurement is this is the indication how the patient adapts to his deformity. So an apparent measurement says that's how the patient walks, that's how the patient be right now to accustom to his deformity. That we have to measure by using an apparent measurement. This is very important because we have to understand the countermeasures or the compensating measures the patient employs to overcome his deformity. Okay, so once we correct all these things, some deformity may be fixed because of duration. So for a shortening, there will be equinus deformity that may be fixed. The correction of the primary component will not be yielding an identical or an ideal result for these cases. We have to we should understand the patient's nature by doing an apparent measurement. Okay, are you clear? Measurement is the key, and it starts with the bony point only. And bony points are standard, and there are methods to identify those things. And there is a method of series of points that has to be connected. Okay. As far as thigh is concerned, proximal femur is cannot be palpated. For that, we are using an indirect measurement called as a Marian's triangle, and the entire lower limb length is compared on the other side by keeping it on identical position. By keeping the pelvis straight, we call it as squaring of the pelvis. Squaring means these two lines are parallel. Okay, whatever the pelvis is lying in a perpendicular fashion, that means these two lines, it can be ischial line, it can be ilial line, it can be at any reference point, it can be shoulder, whatever it is. The point is there is an axial skeleton. That axial skeleton means skull and the spine. And all of the things are appendages, including the limbs and the pelvis. Okay. So the limbs and pelvis are appendages. That means we have to have the straight line in the middle. We call it as an axial skeleton. So once we have it as a straight line, these things are to be perpendicular to the axial skeleton. So we call it a spiral. We will have a 90 degrees from the axial skeleton at any reference point that is perpendicular to the axial skeleton. Okay, that means this anterior superior iliac spine on both the sides will be lying straight. Always it will be straight because the bone is articulated. We are having a reference with the midline. So with the axial skeleton, it has to be perpendicular, 90 degrees. That means these two things are aligned. The rest of the limb is measured with respect to the axial skeleton after making it square. Okay. Any doubts?